global health work includes projects in Brazil, Jordan, and South Africa. So we're very honored to have both of you here to speak to us, and we'll just turn it over to you now. Thank you so much.
Great. Thank you so much to the organizers for inviting me to discuss some treatment and research updates in COVID-19. As mentioned, my name is Yuri van der Heijden. I'm at Vanderbilt University Medical Center and also have an appointment at the Orem Institute in Johannesburg, South Africa. Next slide, please. I don't have any financial conflicts to declare. I do receive grant support for research projects from the National Institutes of Health to Vanderbilt. And I will be talking about treatment today, so several off-label therapies will be discussed, but I won't recommend any of them. Next slide, please. So what I'd like to do today is to discuss some general updates on SARS-CoV-2. And then I'd like to focus attention on remdesivir, which has had a lot of publicity recently. Then I'll talk about some additional treatment candidates and follow that up with some additional research, and particularly as it relates to ethics and considerations for public health approaches. And throughout the discussion, I hope to highlight some areas that I think may be of particular relevance in low and middle income countries. Now, I think it goes without saying, but I just want to mention up front that I will not be able to cover everything related to treatment of COVID-19 tonight. And there's a good chance that even in a few days or weeks, a lot of what I say right now will be old history, we should say. So next slide, please. I just wanted to show this as an update from the 11th of May. This shows a world map, and as many of you know, there was an initial description of cases at the end of December 2019, and since that time we now have more than 4 million confirmed COVID-19 cases throughout the world. The epidemic shifted to Western Europe and now primarily is in the United States with highest numbers of deaths and confirmed cases, and in fact is now on every continent except Antarctica. I wanted to show this as one of many examples of dynamically aggregated maps and figures. So this one is from Johns Hopkins. There are several others from the CDC and others, but I find this to be a good resource that's updated frequently. Next slide, please. So the number of news stories and published papers on SARS-CoV-2 is astounding, and I think in many ways can be deceiving. It's true that we've learned a lot about SARS-CoV-2 so far, but there are still a lot of gaps in what we know. So for instance, just a few categories to think about in terms of the epidemiology. We've seen that there are two major types, S being the first type, but L being the most prevalent and likely more aggressive. But we don't know what the further developments have been in terms of evolution. We remain to see how that will develop worldwide and what the clinical significance is really of that molecular epidemiology. Additionally, it's been shown now, if data from many different countries suggest that males are at higher risk for severe disease and poor outcomes. And not only do we not know whether that's primarily driven by biologic differences or differences in health behaviors, but also the implications for treatment that those differences may carry remain to be investigated. As an example with transmission, we understand that respiratory droplets are a primary mode in which the virus escapes one human host and has the potential to be transmitted to another. But there's still a lot of controversy about the particle sizes that are significant within day-to-day circumstances and also within hospital situations where there may be aerosol generating procedures. Those have direct implications for hospital policies, infection control considerations, and then recommendations to the public at large. And so there's a lot still to be discussed. We've also seen that this virus lingers on different surfaces from hours to up to several days. There's still a lot of work to be done in terms of understanding the viability of post-infectious viral particles that can be detected. And then the types of specimens besides respiratory secretions that may be of clinical importance, such as blood, feces, semen, as examples. Another hot topic that's being discussed a lot is serologic testing. We know that antibodies are induced and can be measured, but we still have a lot to learn about the relationship of antibody detection and the risk for reinfection. This is a big area where we still have a lot of work to be done, as well as following up on the accuracy of the particular serologic tests that are being developed and released for use. Next slide. And as we think about this being really a global pandemic, I think it's really important to mention that this has disrupted other health programs and service delivery for many other infectious diseases, non-communicable diseases, and has also hampered disease prevention efforts throughout the world. So if you look at the image here, you can see TB at the top of the list, but many other infectious diseases that have not gone away or stopped in the midst of the COVID-19 pandemic. Stop TB organization released a model where they suggested that in a situation where the general 3-month lockdown occurs with a much longer period of socioeconomic recovery, that may set the global fight against TB back by 5 to 8 years. That's of course a model, but I think it's an important reminder to us that the service delivery of critical medications such as antiretrovirals, medications against TB and other infectious diseases is a really important thing that we need to think about, particularly as it relates to high burden settings, which often coincide with low middle income countries. The other thing to think about is general prevention, such as immunizations for children, routine cancer screening. All of these things have been interrupted and are important to think about, and can be pose a really big problem in the midst of competing interests in finite resources. Next slide, please. When I originally thought about this lecture, if I had given this a couple of weeks ago, even this slide would have said, as a warning for the rest of the talk, that there's no approved specific treatment. Well, as of a couple of weeks ago, that could be modified. And so before I get into talking about remdesivir, I want to just make one other important set of comments. And that's really for us not to forget the basics of what we know about treatment and prevention. And so this has to do a lot with the importance of our public health messaging being consistent and focusing on steps that we can take, such as you see on the CDC infographic at the right of the slide. Things like staying home if we're sick, avoiding close contact or this physical distancing, which has been set up in many countries, avoiding touching our eyes, nose, and mouth, hand hygiene, and disinfection of surfaces. It's critically important that we're consistent with our messaging, and then that carries through to our healthcare settings, such as clinics and hospitals and infection control programs. It's critical that we don't abandon the principles of evidence-based care, even as we approach investigating new treatments. And then also the more in-hospital treatments that we think of. And as an example, there's a nice paper that's referenced here that looks at really years of important interventional trials that have been studied to look at bundles, checklists, and components of care that shouldn't be abandoned in the face of a disease process like we're seeing with COVID-19. Next slide, please. This slide is a reminder of treatment targets. And what we can see here is that as the virus enters the host cell, there are several steps for replication. And the graphics demonstrate several drug targets. What we'll talk about and really focus on at this time is ribavirin, I'll talk about chloroquine and hydroxychloroquine, and I'll talk about lopinavir-ritonavir. I'll also mention some of the immune modulators. Next slide, please. And this graphic is a reminder for us to consider the presentation of patients with severe COVID-19 as they present to healthcare settings. So as we know, many people may be asymptomatic or have mild symptoms, but for those who really have developed severe symptoms and require hospitalization or potentially even intensive care, it seems that the course of the disease is characterized first by a viral response phase, where early in infection, that then can develop into a worse illness, clinical course, characterized really by worsened respiratory status, and then may develop into ARDS and other attendant problems like shock and cardiac failure and even death. And that latter stage really seems to be characterized by a robust host inflammatory response. And so you can see here at the bottom row, really that there's this long bar for many of these therapies, and that's because we really don't know yet exactly during which phase some of these potential therapies may be most beneficial. And so there are a lot of trials going on. I'm going to mention a few of them that have come out recently, but there are still a lot of trials trying to characterize where along this spectrum they may be most useful. Next slide, please. So let's talk about remdesivir. It's certainly been in the news a lot, and I think as many clinicians are probably interested in understanding when to use it, how to use it, and so forth. So I'm going to talk a little bit about the background for this. First of all, it's a prodrug that's metabolized to an adenosine nucleotide analog, which inhibits viral RNA-dependent RNA polymerase. And it's been shown to be efficacious against SARS-CoV-1, MERS, Ebola virus, and also in vitro against SARS-CoV-2. Next slide, please. So April 29th of this year was a big day where 3 different news announcements were made. I'll take them one at a time. In this slide, you can see a paper that was published in Lancet on April 29th. And it shows, it came from a group in China, and they performed a randomized, double-blinded, placebo-controlled trial, multi-center trial, and they looked at administration of remdesivir for 10 days compared to placebo. Their primary outcome was looking for time to clinical improvement, and clinical improvement was defined according to a 6-step ordinal scale. And they looked at if you look at the graphic to the right, you can see that they had a 2-to-1 ratio. This shows the intention to treat analysis. So 2-to-1 randomization for remdesivir to control. And the hazard ratio that you see there was found not to be significant in terms of their primary outcome of time to clinical improvement. Now, when they looked at a sub-analysis for patients who were started on or were randomized to remdesivir or placebo with symptoms that had gone on for less than or equal to 10 days, the hazard ratio is higher and seems to be potentially, at least if you compare the confidence interval to that shown in the graph, there may be a signal there. So first of all, the thing to note about this study is that it was stopped early, and that's because the tide of infections in the province in Wuhan was decreasing at the time, and so they were having difficulty, and in fact had indications to stop the trial at that time. And so their conclusion was that the findings pointed to a need for larger studies. So if you'll go to the next slide. On that same day, Gilead announced results from the SIMPLE trial, which was a phase 3 open label trial. And this study compared 5-day and 10-day dosing courses of remdesivir. These were hospitalized patients with severe disease. And you can see this as part of their news announcement. if you look at the table, you see that the first data column, it shows the 5 days of remdesivir compared to the next column, which is 10 days of remdesivir. You can see about 200 patients in each arm, and they really did not find significant difference in what they were looking at in terms of the courses, the 5-day and the 10-day courses. So this had an importance for thinking about certain patients in this population being able to have a shorter course, half the course compared to others, which may allow more drug to be distributed in settings that may need it. And then the next slide, please. The last announcement that I'll talk about from that same day was the National Institutes of Health press release. These data, I need to mention from the previous slide from Gilead and the slide here, have not been published in peer-reviewed manuscript, but this was an important news release because it reflected an interim analysis of the ACTT trial. It's an adaptive treatment trial. And in this part of the trial, they randomized patients to receive remdesivir or placebo. And this trial had over 1,000 patients at 68 sites. Those sites were mostly in the US, others in Europe and Asia. And what the interim analysis showed is a median time to recovery of 11 days for the remdesivir arm compared to 15 days in the placebo arm. That was significant. When they looked at mortality, the findings were not significant, but they did favor remdesivir. That was a pretty high mortality rate to begin with, but these findings were enough for to generate a response. And if you'll go to the next slide, and that was for next slide, please. Thank you. We'll go one back, please. Great. And that was a pretty rapid follow-up on the 1st of May from the FDA for an emergency use authorization. So we'll talk in detail about this, but this is really a rapid movement to make it possible for clinicians to use remdesivir in the clinical setting, and not just under clinical trials environment. And so what the authorization allows for is treatment of suspected or lab-confirmed COVID-19 in adults and children who are hospitalized with severe disease. And that's characterized by any of the 4 criteria that you see listed. Next slide, please. And under this authorization, you can see I've put in this box here, and I've linked, there's a link here and at the end of the presentation as well for references in case anyone is interested in looking at it. But there are different suggested doses, first of all by weight, patient weight, and then also whether the patients are requiring invasive mechanical ventilation and ECMO or not. And you can see that the difference is the duration of treatment. And that's really 10 days, up to 10 days versus up to 5 days, and with an extension, a possibility to extend treatment to a total of 10 days in those who are not on mechanical ventilation. So I think the important things to pull out from this authorization are that it's not recommended in patients who have glomerular filtration rate of less than 30. There's caution recommended in pregnancy and patients with hepatic impairment. I think it's also important to think about storage, and this may apply to particularly to limited resource settings where the capabilities of reconstituting the powder with sterile water and saline need to be done with aseptic technique because there's no preservative or bacteriostatic agent in the powder. And then the storage really of the solution is important. It's recommended that it's used immediately for intravenous administration, can be refrigerated for up to 24 hours. And then it's recommended, or actually it's required, that the provider administering the remdesivir needs to give a fact sheet to the patients and parents or caregivers. Next slide, please. It's important also to think about adverse reactions, and there is the potential for an infusion reaction. And then one of the things that's gone into most detail is liver enzyme elevation, which can be difficult to distinguish because in many series COVID-19 patients not on remdesivir but have been noted to have elevation in liver enzymes as well. ALT seems to be the most affected, and many healthy volunteers had slight increases in ALT during the clinical development. It's recommended that liver tests are checked at baseline and daily, and there are these recommendations here that if ALT is elevated more than 5 times the upper limit of normal, it's not started, and it should be stopped if it reaches that, but it seems to be reversible. And also there are other warning signs to look out for, including indications of liver inflammation and lab findings as shown. And it's also mandatory to report adverse events or medication errors. So that's it for what I'm going to talk about for remdesivir. We can talk about it further if it comes up in questions, but now I'm going to switch over, next slide please, to hydroxychloroquine and chloroquine. These are aminoquinolines and are used, have been around for a while to treat malaria, but also as immune modulating effect for lupus and rheumatoid arthritis. There are many hypothesized antiviral mechanisms. Some of these seem to relate to the way that pH is affected with the endosome and lysosomal fusion, but there are some other ideas postulated as well that you can see listed. Next slide, please. So it's been interesting to think about the story of hydroxychloroquine and chloroquine. And these, I've listed here a few studies. These are by no means all of them, but I wanted to just show you that in late March, from the US FDA, there was emergency use authorization outside of the clinical trial setting for these agents. And that was, there were some initial studies. One of the main ones that had attention was this open label non-randomized trial of hydroxychloroquine with or without azithromycin, had a small number of patients, and the endpoint was day 6 viral load, which was shown to be reduced, so that got some attention, so that was 20th of March. Then there was the authorization, and then intervening there were several other small studies. One that was quite notable was a Brazilian study that was a phase 2b randomized clinical trial where they looked at high versus low dose chloroquine. And it's important to note that everyone was receiving azithromycin, and also additionally, several patients were also getting oseltamivir. And so the concern is, of course, for the interaction and additive effect of prolonged corrected QT interval. And in this patient population, they saw that after an interval assessment by a data safety monitoring board, that there was a signal of higher dose, that the higher dose group had increased mortality and corrected QT interval prolongation. And so the trial was stopped at this interval analysis. So that gave concern. And so that led, on the same day, there was the FDA that came out with a caution against its use. So on the whole, there have been several studies. None of them have been large randomized control trials. One that came out very recently in the New England Journal is the observational study that looked at patients who received hydroxychloroquine compared to those who did not. This had over 1,300 patients, and there was no difference found with the endpoint being intubation or death. So I think that a month and a half ago, there was a lot of excitement and enthusiasm about hydroxychloroquine and chloroquine. That has been, enthusiasm has been dampened. There are still many ongoing studies looking at this, but the main thing to remember is that as we use these medications, there can be adverse effects that we need to be very much aware of. I think the other thing to consider is that some of the medication regimens that we use, for instance, for drug-resistant tuberculosis and other conditions, themselves contain QT prolonging medications. So we need to think carefully whenever we're using any kind of new medication about the potential drug-drug interactions. Also, antiretrovirals need to be considered. And so there's a lot of work being done in those areas. Next slide, please. Let's talk briefly about HIV protease inhibitors. I think the important thing to note here was that there was a study that came out that looked at lopinavir-ritonavir. It was a 14-day randomized controlled trial that looked at 14 days of lopinavir-ritonavir versus standard care. And the primary outcome was time to clinical improvement, and that's shown in the figure 2 graphic to the right. And you can see they had almost 100 patients in each arm, and you can see that the primary result was a hazard ratio of 1.31, and you see the confidence intervals there was not significant. And I think the result of this was that there was a fairly widespread dampening of enthusiasm, at least in the way that this trial was conveyed through news outlets. And there's been a response, though. There's actually a compilation of at least 4 or 5 letters to the editor in the New England Journal. And some of the critiques that have been raised about the study are that it was underpowered, and that the randomization occurred late into the course of disease. And additionally, using secondary analyses, there have been some secondary signals that that people have indicated may actually suggest that lopinavir-ritonavir may still be an important part of the armamentarium against COVID-19. It remains to be seen. There are still several trials looking at lopinavir-ritonavir use. I think this is one of those drugs also that may need to be characterized or that has not found its niche yet in terms of the timing within the development of symptoms of COVID-19. So I think there's more to this story, and we'll have to see. I think that's particularly relevant in resource-limited settings with high burdens of HIV, where lopinavir-ritonavir may have been or still continues to be part of at least second-line regimens for antiretroviral therapy. Next slide, please. Continuing with the thought of lopinavir-ritonavir, it was used as part of a triple antiviral combination, and this just came out the 8th of May in the Lancet. That's generated some discussion. So this was a randomized control study where patients were randomized to get 14 days of lopinavir-ritonavir along with ribavirin, and then 3 doses of interferon beta 1b. Those were given every other day. And the comparison group was 14 days of lopinavir-ritonavir alone. You can see there the study numbers, 86 to 41 in the groups. And the results suggested that the combination group had a shorter median time from treatment to a negative nasopharyngeal swab. Now, it's interesting to see, I think it'll be interesting to see kind of the discussion after this study has been out, as people are already talking a bit about it, but what it was, the endpoints it was powered for or not. But regardless, they did show this difference of 7 days versus 12 days to negative nasopharyngeal swab. It is important to note that a substantial proportion of patients in the combination therapy group did not get interferon beta 1b. So I think some secondary analyses may be in order to see what signals are really there. But the implications are that early treatment with triple antiviral therapy may shorten the duration of virus shedding, alleviate symptoms, and hopefully facilitate discharge of patients with mild to moderate COVID-19. I think we'll have to think about the scalability of the use of this combination, but I think there will be more follow-up to this. Next slide, please. There's also a lot of discussion about immune modulators. And so this relates to the finding of the cytokine storm. So on the latter part of the course of disease. And there are lots of different targets that have been reported and are being studied. You can see a list of these here. There are anecdotal reports of good outcomes with use, and you can see a lot of these studies being done. I'm not going to spend a lot of time on those. I will mention that there is a study that's being conducted. It's an international study looking at the use of colchicine. And I think the big factor here is probably the widespread availability of colchicine and the fact that it will likely be much less expensive than any of the other immune modulators that are listed above it on this slide. Next page, next slide, please. There's also been a lot of discussion about convalescent plasma. So this is the use of antibodies in patients who have recovered from infection. This technique has been used for influenza, for SARS-CoV-1, for MERS, Ebola virus, and there have been reports of success with that in the past with these other viral infections. There's a case series that's referenced here of 5 severely ill COVID-19 patients in China who had improvement. Again, this is a hot topic, and I think we'll be seeing, we'll look forward to results from further study in these cases. This may be something that can be applicable widely if the correct equipment is available. Next slide, please. I'll mention just one other of many different compounds that's being discussed. I think the importance here of this N-hydroxycytidine, NHC, and its prodrug that you see listed here, that the fact that they're orally bioavailable and appear to be potentially broadly, have broad antiviral properties, not just against SARS-CoV-2, but other coronaviruses, may be an important finding that could have potential for both treatment and prevention. But again, these are early parts of the studies. Human trials are pending, and so this will be a story that we'll need to see how it unfolds. Next slide, please. Similar to that, you can see other considerations that I'm sure many people have looked at or heard about at least, and studies are on their way, but we don't have results yet to really guide us, at least well-conducted studies to guide us as to their use. Nitazoxanide, ivermectin, vitamin C, vitamin D, and zinc have been talked about a lot. Vaccines I've grouped in this because we're still awaiting a lot of results here. You can see the graphic to the right, which shows a snapshot of at least from April, where a lot of the vaccine studies are in terms of the stage and what types of, what the mechanism of viral, of vaccine it is. Next slide, please. I want to mention just the benefits and risks of new treatments we think about. So there are, of course, possible benefits of using new treatments. So decreased viral activity, disease progression, even potentially cure, decreased transmission to others. There's also risks we need to consider. And I think this plays part in the discussion that many have had regarding how we balance compassionate use of potential treatments with performing rigorous randomized control studies or other rigorous study methods that will allow us to really know whether treatments work or not. And these risks need to be considered. So there are risks of known and unknown adverse effects. There are costs. There's really the inability to see the true efficacy of treatment if everyone begins using it. There's also delay in defining the most appropriate care for future patients, future potential outbreaks. And then also there's the use of medications like we saw with hydroxychloroquine for people who have other medical conditions treated with those medications. Next slide, please. There's an interesting perspective piece that I've referenced here, and I think the highlight really is from part of the abstract, where they note that shortages and increased market prices leave all countries vulnerable to substandard and falsified medical products, and safety issues are especially concerning for Africa because of its healthcare system limitations. So next slide, please, or next forward. And this is not specific to Africa. This is all over. This was a story from the US. You know, these are sensational headlines, but I think the point is that the messaging that we give as healthcare providers and that occur in the news media do have an effect, or may have consequences for people that we're trying to care for. And so we need to be wise in the way we interpret data and the way we make recommendations for treatment. Next slide, please. The other ethical things that could be a very long discussion, but I just need to highlight, there's equity of access to care. This occurs at community levels, implications of pre-existing disparities. There's a global context to consider, countries and societies that have power and are able to leverage limited supplies of equipment and treatments that needs to be considered. We also have to think of rationing of scarce resources all around. And then I think also an important aspect that doesn't always get considered is conducting research in low and middle income countries, and that the benefit of those trials needs to also be distributed to the populations in which those studies occur. And so interventions should be favored and should be considered for study if they're affordable, available, and they need to be adaptable and scalable in the populations in need. There's some resources here that I've referenced that may be of interest for further reading. Next slide, please. Finally, just some last updates as we wrap up. This is a slide from a skilled nursing facility in the United States. And the point I want to make is that there are a lot of studies that have demonstrated over the last several months increasing concern for asymptomatic or pre-symptomatic patients who are infected with SARS-CoV-2. This graphic shows, if you look at the x-axis, you see the 0. It's not quite in the middle, but to the left of that are days going backwards, days from evidence of fever, cough, or shortness of breath. And I think it's quite interesting to see that the red circles denote positive cultures for SARS-CoV-2. So you can see that up to 6 days before patients had symptoms, they had positive cultures. And so I think that's really important to think about, particularly in places with limited resources where we have to really think about containment and strategies, public health strategies to decrease transmission in the community. Next slide, please. And so one caution and one avenue to consider is universal masking. Here, this is a model. Again, this is not peer reviewed. It's from a preprint. Next slide, or next advance, please. But this was a modeling exercise that looked at the percent coverage of participants or individuals in society masking. And it showed that if you look at the red bar, that shows 80% masking that continues after a social lockdown is lifted. And you see that that helps bring the rest of the curve down for percent of the population that's infected. If you see even just 50% masking is not as effective. And if you just have social distancing after a lockdown, that's the big gray bar that has a large rise. Next slide, please. An additional graphic from that same modeling study demonstrated those same categories, and it really shows you that 80% masking, so widespread uptake of the masking done in society, showed that it would be most likely to have lower deaths, and I think is substantial here. Again, these are just models, but I think it's important to think about how we formulate public health policies and what we recommend. Next slide, please. So in summary, I think it's important for us not to forget basics for prevention and treatment in this global pandemic. There are emerging therapies, both new and old drugs that are plausible, but they have unproven efficacy. And it's important for us to have well-designed studies to evaluate treatment candidates. We do need to be cautious and consider potential consequences of using unproven therapies. And I think that an important point is that it'll take thoughtful leadership and wisdom for us as we think about ethical distribution and advocate for the ethical distribution of new treatments, development of public health policies. Next slide. There are some references here. I've made references to the studies that have shown throughout the presentation that I believe will be available for review. This is not an exhaustive list of references, but I've categorized just some hopefully helpful ones for maps and aggregated data, guidelines, next slide please, and also some releases regarding the specifics of remdesivir. Next slide please. And to conclude, I just want to say thank you, and particularly thank you to all of you, colleagues in low resource settings, many of you on the front lines taking care of patients. This has not been easy for anyone I know around the world, but thank you in particular for the work that you're doing.
Thank you so much, Dr. Vander Heijden. That was wonderful. We're now going to have a question and answer time. If you do have any questions, please put them into the chat. We did have a few areas of interest that came through in the registration. Joining will be Dr. Aronoff as well, who will answer questions, and it will be moderated by Dr. Mark Newton, who is also from Vanderbilt University and has practiced anesthesiology in low resource settings for over 22 years. So thank you all, and Dr. Newton, let's get started with you.
Right. Thank you, Sherry. Thank you, Yuri, for your presentation. So some of our questions came in during the registration, so I'll try to clump them. And first of all, we just thank you for that presentation. It was very good. It's amazing. The first question talks about pneumonia and COVID. And the question is that in the low and middle income setting, at times we are not able to do culturing or anything like that. And so the question is that if you have a patient that is known COVID positive, should you go ahead and automatically treat them with antibiotics? And which antibiotics should those be?
I'm going to let Dr. Aronoff jump right in because he's been a part of our COVID huddles in the hospital, and I know has addressed this question.
Yeah, I would be happy to address this. We have had about somewhere between 160 and 170 COVID patients in our hospital. So not a lot compared to some other cities in the United States. And at any given time, so far we have about 25 patients in the hospital with COVID. Our Division of Infectious Disease helps to treat these patients on a daily basis. We participate in multidisciplinary clinical huddles that Dr. Vander Heijden referred to that include people from the Division of Infectious Disease as well as experts in pulmonary critical care medicine, oncology, and general internal medicine as well. And I've been on pretty much every clinical huddle since we started doing that in March. So I've seen the chest x-rays, the labs, and discussed the patients for probably the majority of these 165 patients. The question is a really good one that we deal with almost every day. The patient who presents with often a bilateral pneumonia on chest x-ray, high fever, and hypoxia that looks like community-acquired pneumonia, bacterial pneumonia, even an atypical pathogen like Legionella or Mycoplasma, for example. In any other circumstance outside of the COVID-19 pandemic, such a patient would likely get started on a beta-lactam antibiotic like ceftriaxone and some sort of coverage for atypical microorganisms like a macrolide, such as azithromycin, or less commonly clarithromycin, or sometimes a tetracycline like doxycycline. This would be the typical therapy. But we're seeing some clues that we don't have to do that for these patients. First of all, when they test positive for COVID-19, that's a really good tip-off that their entire illness is due to COVID-19. We're not seeing really any evidence of co-infections being a major problem where COVID-19 is the primary problem and a bacterial infection is a secondary problem. In some of our intubated patients who are on mechanical ventilation for a long period of time, of course, they can get ventilator-associated pneumonia that tends to present as a worsening along a chronic or subacute course in the intensive care unit. But up front, we're not seeing co-infection. Patients with COVID-19 more often than not have a non-productive cough, which makes getting cultures from the respiratory tract challenging. So we often have blood cultures, but no respiratory tract cultures. The other things that help us when we think about withholding antibiotics is the fact that these patients more frequently than not present with a leukopenia. Their white blood cell count tends to be low or normal and not elevated like we see in bacterial pneumonia. That's not always the case, but more often than not, somebody will come in with a white blood cell count that is either normal or low, bilateral, fluffy, patchy, chest x-ray infiltrates, and high fever, and sometimes quite dramatic hypoxia. In some laboratory facilities, we can measure procalcitonin, which is a test that is usually normal or low in patients with viral pneumonia and high in bacterial pneumonia. We know from literature coming out of China that procalcitonin can be elevated in severe SARS-CoV-2 or COVID-19 infection. So when people are in the intensive care unit, even if their illness is entirely due to COVID-19, procalcitonin may not be low. But for patients who are not in the intensive care unit and have mild to moderate or moderately severe disease, we are finding that procalcitonin is generally low as well. So the short answer to your really great question is, in the presence of a low or normal white blood cell count, a positive COVID-19 diagnostic test, and a clinical illness that fits the picture of COVID-19, it is perfectly reasonable to withhold antibiotic therapy unless you have any other evidence to suggest that there's a concomitant bacterial infection, which so far we have found to be uncommon. Yuri, is that a reasonable answer?
Yes, I agree.
Okay, great. Thank you. Second question was about steroids, and knowing that steroids certainly are available in Southeast Asia and in Africa, what would be the clinical scenario where you would add steroids, and which steroids would you add, and for how many days? What dose for an adult?
I can maybe opine here and tell you that here our pulmonary and critical care specialists have looked at the data and are not using corticosteroids routinely in COVID-19. The cases where we've entertained its use have been in some patients who look like very late in disease. They've developed an organizing pneumonia. In some of those patients, there's been the use of corticosteroids, but I think the whole, and Dr. Van der Heijden touched on this some in his talk, so I'd be very interested to hear his perspective on the world's literature. But it seems highly controversial, and at this time, that's not part of our standard pathway of care.
Yeah, the short answer is that I've not seen any overwhelming evidence to support its broad use, other than for the standard clinical indications in an intensive care unit setting or otherwise that steroids would be used.
Okay, another question was about malaria and COVID-19, and trying to differentiate between the two?
That's a great question, and one that I have not had to face clinically, but I'm sure many people in other settings have had to think about a lot. You know, what we know is that there are kind of some central symptoms that seem to predominate with COVID, though of course there are many other symptoms that may accompany fever, shortness of breath, and cough. Are kind of the hallmarks that people are talking about. Of course, fever overlaps a lot with malaria. We classically think of fever and headache, but you can also see headache in reports with COVID-19, as well as the myalgias and arthralgias that you would see. So I think there can be quite a bit of a clinical overlap syndrome. I would suggest that based on what I understand from the literature, shortness of breath would be one component along with cough that may help, in general, may be a distinguishing feature between the two overlapping disease processes. But I'm not sure that apart from a blood smear that may help diagnose malaria on site, if the capability is there to perform that, or a rapid test for COVID-19, I'm not sure that clinical symptomatology may be a great way to distinguish the two.
Okay.
Do you have any additional input there?
No, I think that's a great answer. I would say, you know, the anemia would probably be more common with malaria than we're seeing with COVID-19, but I do think it's going to be based on doing rapid testing, like molecular testing for COVID and blood smear or antigen testing for falciparum or other plasmodia. But that's going to be an important challenge in areas where those infections coexist, for sure.
Mm-hmm. Okay, thank you. So there were a number of questions about remdesivir, and some of the questions were, is it available in Southeast Asia or in Africa? And things like cost and side effects in situations where we may not be able to measure LFTs. And clinically, how would we treat and then monitor?
Yeah. I don't know the answer to a lot of the components of that question. The supply chain for remdesivir is ramping. As I understand it, the production is certainly ramping up. I know that there are hospital systems here in the U.S. that are asking for when they will be able to get remdesivir. And so, you know, suggesting that there are many here who don't have access to it. And so I don't know what the international distribution is like, but I suspect that there may be some delays for people around the world in being able to obtain remdesivir. I also don't know what costing will look like in international settings. Many drug companies have worked out deals to provide reduced costs to low and middle income country settings, and I don't know what those negotiations look like at this time.
Okay.
The side effects question is important. Outside of the recommendation, which under the US FDA guidance is to get the baseline ALT and daily and checking it daily, I'm not sure. I think that characterizing renal function and liver function is going to be important in thinking about this medication. And I say that particularly because of, as I mentioned in the presentation, during development, a high proportion of individuals, even healthy individuals, had elevations in their ALT. Now, again, most of those were minor. The data reported in the publications, the published literature on remdesivir, do show that there are, it's a range probably from what I remember seeing, in the 15 to 25% range of people who had elevations. There were not many who had severe, so grade 3 or 4 adverse effects, but there were plenty there. So I don't know, that would be, I think, a discussion that would need to occur probably on an individualized healthcare setting. But I would probably use caution in using a medication without being able to monitor its effects.
Okay. So we have time for maybe one more question, and this is just a general question that may wrap up a number of the questions. But the main question is, since these therapies are emerging and we really don't know exactly what drugs are best to treat, if you were in a low and middle income country advising the Minister of Health in the country that doesn't have access to many of these drugs, what would be your algorithm for treating COVID-19 with what we have? With the use of, we have ARVs and we have chloroquine.
Yeah.
Yuri, do you want me to take it?
Yeah, I'd love to hear what you have to say.
Yeah, I think part of what makes knowing what to do so difficult is that the natural history of the disease is quite different in different people, and we don't really yet understand the basis of why some people do poorly and some people don't. There's really a large range of how people behave with COVID-19 and how they recover. And some people recover for a little while and then get worse. That variability makes it very difficult to rely on anecdotal data, because people can apply almost any treatment and see that a patient may get better. But it's really hard to know if that's due to chance or not. One thing that we are doing in clinical trials that shows some promise and is easy relatively to do for people with hypoxia is prone positioning. So laying people on their stomach seems to lead to some spontaneous relief. Patients feel better, and they tend to oxygenate better if they're having problems oxygenating. And that's a maneuver that has not been definitively studied to be of benefit, but it looks promising, and it's obviously can be done just about anywhere. I think really just very good supportive care is important, and if you have the capacity to measure pulse oximetry, that can be useful. One thing we're finding in these patients, they can have profound hypoxia and be quite tachypnic, but not feel short of breath. And they can say that they feel fine until they need to get intubated, essentially. And I don't understand the basis of that, but we see it not infrequently. And so not trusting somebody who says they feel fine, but getting data from their fingertip with a pulse oximeter or some other way to measure oxygenation is really probably very helpful for understanding how sick somebody really may be.
Thank you very much for that discussion. And I think this leads us to an opportunity with people on this call in Southeast Asia and then tomorrow morning in Africa, is that there will need to be studies done in low and middle income countries. And so that maybe there's collaborators even on this call and those in Africa tomorrow morning to discuss some of the potential for partnerships and collaboration and studies. So I want to thank you both for educating us all tonight, and I'm going to turn it over to Sherry and to close the session out.
Thank you so much, and thank you all of you for such a wonderful presentation and really relevant and interesting conversation. We do want to continue this conversation on, and so Claire is going to share with you right now how to continue that through WhatsApp.
Yeah, so we invite all of you to join our WhatsApp chat group, and you can do that by scanning this QR code with your cell phone. We'll also send out a link via email if we have your email address. Feel free to join the group and ask us questions there or share what's happening with COVID in your setting. If you have any difficulty joining the group, you can email us at echo@assisinternational.org. Thanks.
Thanks, Claire. And again, thank you, Dr. Heijden and Dr. Aronoff and Dr. Newton. This was really a wonderful presentation. We're going to put up a short poll as you leave. We'd ask if you would please fill the poll out before leaving. And we do appreciate your time here. We know that your time is really valuable, and just want to wish you all the best as you doctors and nurses and healthcare providers all over are really at the forefront of fighting this pandemic. And so we're grateful to all of you and look forward to seeing you again next week.
Thank you.
Thank you.
Thank you.
Thank you. And for the presenters, we will see you early tomorrow morning. You don't have to stay on while people are taking the poll if you want to get off. We know you're very busy, but just really appreciate your time.
Thank you for having us.
Thank you.
What an honor.
Thank you.
Bye-bye.
Bye. We'll be shutting off the poll in just a moment. So if you can finish up your answers, we'd really appreciate that before you leave. All right, thank you again, and we'll see you next week. Bye.